This is the second video in a series of modules on glaucoma training. Module 2. What are the challenges? The learning objectives for this module are understanding why people present late with glaucoma, knowing pros and cons of treatment options, understanding the patient experience, learning essential patient information and communication, and understanding gender equity issues in glaucoma. Unfortunately, many patients present to the eye clinic with advanced glaucoma disease. The usual presentation is with one eye blind and the other with moderately advanced disease. This could be because they are not aware of glaucoma and do not understand how important it is to seek help. The term glaucoma may not be known by many people. Those who know the term have different ideas about what it means. There often is no local word for the disease. Some know it as black blindness, as opposed to white blindness in the case of cataract. Different people have different ideas about the causes of glaucoma. Some think it is caused by excessive crying, excessive anger, or excessive exposure to firewood smoke. Others relate it to black flies or confuse it with river blindness. Some understand it as hypertension of the eye, but very few people relate it to death of the nerve of the eye. So what prevents people from coming forward early enough? The main reason is the lack of symptoms. This, together with poor awareness of the existence of the disease, means that people wait until the eye is blind or there is substantial loss of vision before they come. Also, people know about cataract and tend to wait until the cataract is mature before they come in for an operation. So those experiencing some sight loss often assume they have cataract, and by the time they come, it is too late to save their sight. People also waste a lot of time seeking alternative or traditional medication. This is because in many communities, traditional healers are more easily available and accessible. They come to the patient's house and offer their services, which the patient is often unable to refuse because the healers are recommended by influential relatives, and they may initially offer free service or service on credit. Treatment provided by traditional healers can sometimes cause physical harm, but perhaps the most serious consequence is that this will cause a delay in patients seeking and receiving the correct medical treatment. The consequence of this delay is very often frustration for the health worker, grief for the family, and irreversible blindness for the patient. The key to getting patients to treatment sooner is to create awareness, emphasizing the lack of initial symptoms and urging the people most at risk to go for a checkup. These are people with first-degree relatives with blindness or glaucoma, people wearing glasses for myopia, those on long-term steroid treatment, and all adults over 40 years with diabetes, hypertension, or a history of trauma to the eye. Radio and television can make a big difference to fill clinics with people who either think they have the condition or want to be screened for it. So these kinds of programs, done often enough, will reach more and more people in the community and will reduce the level of ignorance about the disease in the community. When considering treatment options, the cost of eye drops is a major barrier against adherence to treatment in patients. The cost of 1 month's treatment with the more effective drugs can be more than the minimum wage in the country. Although there are cheaper generic medications on the market, they may not be available. Surgery is usually trabeculectomy and has the benefit of being a single procedure. When successful, it maintains the pressure for a long time. However, surgery has its problems too, as the rate of failure of the filter is high in African patients, and therefore regular follow-up is important. Another problem is that some doctors are reluctant to operate on patients if they have advanced glaucoma because of the risk of wiping out the remaining vision. If a patient does lose their vision after surgery, she or he may attribute that to the surgery, not the severity of the disease. Cases like these may give a clinic and the doctor a bad reputation and drive away patients. Laser treatment, such as selective laser trabeculoplasty or SLT, is a good option where available. It is non-invasive, affords reasonable control over a long period of time, and can be repeated. Distance to glaucoma clinics is one of the reasons that stops patients coming to hospital. One way to remove this barrier would be to establish outreach clinics in communities, staffed by nurses and allied eye care personnel, able to recognise glaucoma and refer patients. When considering how to improve the rate of people returning for their follow-up visits, make sure that they are receiving sympathetic attitudes from healthcare workers. Also, make sure they are not subjected to long waiting times before being seen. That there is an efficient system to retrieve their records by improving record keeping and filing systems, and that they are taken on a strictly first come, first served basis, and there is no queue jumping by some patients. Our communication with patients must also improve. Many patients come to the hospital and receive treatment without knowing what they are being treated for. Health workers must explain patients' diagnoses to them, say what glaucoma is all about, how it will impact on their sight and life, and discuss the management options with the patients. Patients sometimes stop using their eye drops because there is usually no improvement in vision and no relief of symptoms, as they had no other symptoms to start with. Therefore, there is little to motivate them to persist with their treatment. Continuing deterioration in vision is an issue, even if patients who continue to use their medication as prescribed. When this happens, patients feel that their treatment has failed and they visit traditional healers instead of coming back to the clinic to find out about alternatives, such as surgery. Traditional healers are often allowed to advertise on television and on local radio, and sometimes actively encourage patients to stop treatment. By the time patients come back to the eye clinic, they are often irreversibly blind with no light perception after having tried and lost faith in the traditional healers. They come back broken, despondent, and desperate for anything to restore their sight. To ensure patients continue with their treatment, we must ensure that they know the following. 1. Their vision may not improve even when the treatment is effective. 2. There may be slight deterioration in their vision over time, even when on medication, as the treatment is not a cure, but a control to delay blindness for as long as possible. 3. Patients should continue with their treatment even if the eye is completely blind. Doing so will prevent them from having a painful blind eye or a discolored eye from corneal decompensation. Consider using strategies that motivate, empower, and commit the patient to change their behavior and improve their control of the glaucoma. Some eye clinics are exploring the use of motivational interviewing administered by trained counsellors to achieve this. Evidence suggests that women account for about 55% of people with open-angle glaucoma and 70% of people with angle closure glaucoma. There are very few studies on service provision. However, in Tanzania, women account for a smaller proportion of people receiving surgical intervention for glaucoma, and in Malawi, women who are suspected of having glaucoma are less likely to be referred to secondary facilities for assessment. Hospitals should be monitoring the use of medical and surgical services for men and women separately. If you note more men receiving services than women, you should investigate. Screening programs are rare. Where they exist, findings for men and women should also be assessed separately. Use the findings to revise the program. Qualitative research is needed in a number of settings to understand any differences in how men and women with glaucoma seek help, whether medical or surgical. Use this information to develop gender-specific educational materials and programs. In many settings, coming to hospital or clinic is difficult for women. Programs should aim to create a more dynamic network to enable follow-up. That concludes Module 2 on what are the challenges with glaucoma. Coming next is Module 3, Advocacy and Raising Awareness of Glaucoma. Write down any questions you have about this module and be sure to have them answered. Ask yourself, what am I going to do as a result of this learning? Check that you have achieved the learning outcomes for this module. understanding why people present late with glaucoma, knowing pros and cons of treatment options, understanding the patient experience, learning essential patient information and communication, and understanding gender equity issues in glaucoma.